Today we're pleased to welcome Dr. Valerie Vaughn, a very special guest from the US. Dr. Vaughn is a practicing hospitalist and health services researcher. Her work focuses on improving the safety of hospitalized patients by combating healthcare-associated infections and reducing antibiotic overuse, particularly at hospital discharge. Dr. Vaughn is also an assistant professor of medicine in the Division of Hospital Medicine at the University of Michigan and VA and Arbor healthcare system. So, welcome, Dr. Vaughn, and that you have a great lecture.
Thank you. Great. Bom dia e muito obrigada. I have to admit that's the only Portuguese I know. I actually tried to take a Brazilian Portuguese class my senior year of college, and they set it up for 7 a.m. Monday through Friday. And so I'll admit I lasted 4 classes before I decided that sleeping in was more important. But I really appreciate all of you coming today, and Dr. Barcelos for inviting me, and Wallace for that wonderful introduction. I know I've been talking to a few of you, and I know that you guys are all going through a big surge around COVID right now and a high volume of cases. So I want to let you know that our thoughts are with you, and I really hope things get better for you guys. Today, I'm going to talk about some of our experiences and what we've learned from our surge earlier this year in Michigan. And I hope that maybe some of those things can help you guys as well. And then I'm hoping we can have a little bit of time to talk and have some questions at the end of my talk as well. Specifically today, I'm really going to focus on antibiotic use and how through good stewardship, we as hospitalists, as physicians, can help slow really the other pandemic that's really happening around the world right now, that of antibiotic resistance, and talk about how antibiotic use, antibiotic resistance, and COVID-19 really come together and how we can combat both of them at the same time. So to start us off, I want you all to think about what you currently do when it comes to patients with COVID, and think about how you would handle the following situation. So let's say that you were to come in and you have a patient that's being admitted to the hospital to you with what you believe to be COVID-19, but the test result is currently pending. The patient has a fever to 39, a heart rate of 110, a respiratory rate of 25, and he's saturating 86% on room air. He's short of breath and has a dry cough, and really he just looks unwell to you. His chest x-ray is consistent with a multifocal pneumonia and likely COVID-19. So while we're waiting for the COVID-19 test, would you prescribe antibiotics? I want you to think for a second about what your answer would be. Would you prescribe antibiotics and also cover for influenza? Would you prescribe antibiotics but maybe not prescribe or cover for influenza? Or would you not prescribe antibiotics but make sure you're treating influenza? Or would you not really prescribe anything while waiting for the test? So this is kind of the question that I think I initially was thinking about when we took care of patients with COVID, and was really a question, and I don't think any of us knew what the right answer was. And it's even harder when you don't have a COVID-19 test back. So I want you to think about what your answer is in this situation, and then say, would that change if you knew for certain that the patient had COVID-19? So you had the test result back and the test result was positive. So we're going to talk about those things and the answers to some of those questions and how I think through it, and really how we thought through it kind of early on during the pandemic. This is a picture of my team of hospitalists. This is actually the top floor of our children's hospital, where we took an entire unit that used to be for pediatric patients and turned it into an ICU for adult patients with COVID. And these are all hospitalists who don't normally take care of patients in the ICU, but volunteered to take care of the sickest patients because we were really overwhelmed at the point of time. You know, so and the reason that the antibiotic use issue became something that was so important to me is I actually had an experience with one of my own patients during this time when I was taking care of a patient on this unit. The patient came in April 1st with hypoxia, diarrhea, and a fever, and was diagnosed at that time with COVID-19. There was a C. difficile test done at the time, which initially was negative. The patient over the next few days developed kidney failure and started having lower urinary output. Patient was given antibiotics just in case, which is something we were often doing for patients at that time. And then fortunately, the patient actually started feeling better. And so within a week was off oxygen and was starting to move around. We were thinking about discharging the patient when the patient started developing abdominal pain and bad diarrhea. Became hypotensive. We ended up giving 6 liters of fluid. The patient, because of the renal failure, actually got worse, stopped urinating, and became fluid overloaded. We actually had a long conversation with the family, who decided to withdraw care, and the next day the patient passed away. It was at that point that the C. difficile test came back positive. So I actually had 3 patients kind of in a short period of time that ended up having C. difficile after they'd had COVID. And so this really made me think about the fact that we were using so many antibiotics. Is this an okay thing, or is this the wrong thing? Because there tends to be a problem with antibiotics and that they're not really safe and benign drugs. We know from other studies that they can cause side effects or adverse events in up to a quarter of hospitalized patients who receive them. Those adverse events can range to mild things like diarrhea or nausea to severe things like, in this patient's case, C. difficile and death. They're also a large driver of C. difficile infections generally, and we know that even short durations of antibiotic therapy can double a patient's risk of C. difficile. They're a risk factor for recurrent C. difficile, and that if you decrease antibiotics, for example, in a hospital or in a neighborhood, you can actually reduce hospital onset C. difficile rates. So it's not just about the single patient, but it's also about the community and other patients that are also in that hospital. And then obviously antibiotics are also associated with the development of antibiotic resistance and drug resistance more generally. There are now things we have to worry about like MRSA and VRE, or multi-drug resistant gram-negative infections. And we know interesting things like, again, it's not just a single person, but the amount of antibiotics consumed in a neighborhood is linked to the amount of resistant E. coli in that neighborhood. So again, this is not just a single patient thing, but it's something that affects the neighbors and the society around the patient. And we also know that there are lots of antibiotics used. In the United States, up to half of hospitalized patients receive an antibiotic at some point during their hospitalization. So commonly used, lots of side effects, lots of big problems that we need to think about. And in fact, the World Health Organization back in 2015 really issued a rather dire warning about antibiotic resistance, and said that antibiotic resistance threatens the very core of modern medicine and the sustainability of an effective global public health response to the enduring threat from infectious diseases. Systematic misuse and overuse of these drugs in human medicine and food production have put every nation at risk. Few replacement products are in the pipeline. Without harmonized and immediate action on a global scale, the world is heading towards a post-antibiotic era in which common infections could once again kill. In other words, there's this slow-moving pandemic that's occurring at the same time, but the problem in this case is antibiotic resistance. The good news is obviously we can do something about this. Each of us has the ability to improve and reduce our antibiotic prescribing, and we can actually combat this in real time to try to prevent the dire consequences. But that leads us back to our current patients and those with COVID-19. And the question of, do patients with COVID need empiric antibiotics when they come into the hospital? What we know from the past is that there's potentially a high risk of bacterial co-infection in patients with COVID. If you look back at the 1918 influenza pandemic, most fatalities were actually linked to subsequent bacterial infections, particularly from Streptococcus pneumoniae. And early reports and pathology reports of patients with COVID who have died show that up to half of those who die from COVID have a bacterial co-infection at the time of death. So there are obviously reasons to be concerned about bacterial co-infections and the need for antibiotics in these patients. So that's kind of the background about what I want to talk to you all about today. And I'm going to briefly go through a couple of different sections. I want to introduce you first to the collaborative that I work with called the Michigan Hospital Medicine Safety Consortium, because that provided a lot of the infrastructure and background for this work. I'll talk a little bit about our pre-COVID stewardship work in that area, and then switch gears and talk about how we morphed and merged what we were doing with the Hospital Medicine Safety Consortium into My COVID-19, which was a huge collaborative that we created to combat and improve care for COVID-19. And then specifically talk about what we found related to antibiotic use and co-infections in hospitalized patients with COVID-19, and then leave you with a few takeaways and some time for questions. So first off, a quick introduction to the Hospital Medicine Safety Consortium. The Michigan Hospital Medicine Safety Consortium is one of 17 collaborative quality initiatives in the state of Michigan. These 17 collaborative quality initiatives are funded by Blue Cross Blue Shield of Michigan, which is actually one of our healthcare insurers. And unlike some insurance companies, Blue Cross Blue Shield is very interested in how they can use insurance and use the money from insurance to improve quality of care for patients. And so they've funded our initiative with the overall goal of improving the quality of care for hospitalized patients in the state of Michigan. We've had 4 initiatives over time, and the most recent ones, which really ended up being a good setup for taking care of patients with COVID, was one related to antibiotic use and one related to sepsis care. The collaborative includes over 50 hospitals from across the state of Michigan. If you look, we really have diverse hospitals. So there's a big cluster down here in Southeast Michigan where Detroit is. This is Ann Arbor, where I live over here. And a lot of the big academic medical centers are here. But if you look up in northern Michigan, and especially up here in our Upper Peninsula, these tend to be small hospitals, community hospitals, very few beds, and a very different patient population. Some of the hospitals are for-profit, some of them are not for-profit, and so there's really a diverse kind of group of hospitals here that we collect data from. The way that we work is really through multidisciplinary collaboration. Obviously, the Hospital Medicine Safety Consortium starts with hospitalists, but we've collaborated with ID physicians, with intensivists, with pulmonary critical care physicians, and then also with pharmacists, nurses, vascular access technicians, quality leads, data abstractors, basically a whole huge team that really helps us to do a lot of this improvement work. And the way that we actually improve care is first and foremost by getting good quality data from the hospitals, and then we share that data across the hospitals. We also share the best practices of those hospitals that are doing particularly well. And then we do something called facilitated implementation, where we go to hospitals that maybe aren't doing that well, and we try to identify what problems they have and how we can actually work to fix those problems. So up until now, the big thing that I've focused on, the big area of initiative that I've focused on within the collaborative is what we call our antimicrobial use initiative. This started back in 2015 with the goal of improving antibiotic use in patients hospitalized with pneumonia or urinary tract infection. And we focused on 2 kind of main ways to improve antibiotic use in this population. The first was trying to reduce treatment of asymptomatic bacteria, and the second was trying to reduce and improve antibiotic treatment duration in patients with community-acquired pneumonia. So what's asymptomatic bacteria? Asymptomatic bacteria is when there's bacteria in the urine of a patient, but they don't have any symptoms of urinary tract infection. So this is actually very common in patients, especially in older patients, especially in women, especially in those who have had urinary catheters or other interventions in the past. And what we know is that typically asymptomatic bacteria shouldn't be treated. There are some exceptions if a patient's pregnant or undergoing urologic surgery, but otherwise treating asymptomatic bacteria doesn't improve outcomes. And so with data from the collaborative, we actually looked at treatment and outcomes of asymptomatic bacteria in hospitalized patients. And we found across our collaborative that 83% of patients with asymptomatic bacteria received antibiotic treatment, all of which was unnecessary and inappropriate. And that patients who were treated with antibiotics had a 37% longer length of stay. And I don't know about you guys, but our hospitalists really care about length of stay here. It's often linked to our payment. It's often really pushed down on us that we need to reduce our length of stay. So this is actually something that we've used and talked to people about to try to get antibiotics not to be prescribed for asymptomatic bacteria. The other thing that we've really focused on is community-acquired pneumonia. National guidelines from the American Thoracic Society and the Infectious Disease Society of American really say that antibiotic duration for patients with CAP who are stable and no longer febrile should be 5 days. And if you've looked at other studies and kind of in our hospitals and elsewhere, that means that about 87% of patients hospitalized with community-acquired pneumonia really should get 5 days, and only the sickest of the sick should get longer than that. We looked at this across our collaborative again to see what was actually happening, and we found that 2/3 of patients hospitalized with community-acquired pneumonia received excess antibiotic duration, and that each excess day of treatment was associated with a 5% increase in the odds of an antibiotic-associated adverse event. So it caused direct patient harm. We also found, interestingly, that all of this excess duration happened at discharge. So in the United States, the length of stay for a patient with pneumonia is generally somewhere between 3 to 6 days. So if you're asking for patients to only be treated with 5 days of antibiotics, most of the excess duration occurs after they leave the hospital. And this idea of the discharge as being a big place to look at antibiotic use actually led us to look at other types of antibiotic overuse. And there's a lot of information on this slide, but basically what it's showing you is each bar is a hospital. The y-axis shows the percentage of patients with antibiotic overuse at discharge. And then each of the colors shows a different type of antibiotic overuse. And what you can see generally is just there's a wide variation and a lot of overuse that happens at discharge. At some hospitals, for example, this one over here on the left, nearly 80% of patients have some sort of antibiotic overuse when they're discharged. A lot of that is from unnecessary antibiotics, for example, antibiotics in patients who don't need and don't have an infection. And then a lot of it is also from excess duration, this kind of green color here. So there's a lot we can do to improve prescribing at discharge. And this is kind of what we started focusing on within the collaborative. And we focused on it by doing 3 things. So we shared data. We started doing pay for performance, where hospitals actually got reimbursed for how well they were doing on our quality metrics. And then we did the facilitated implementation, like I mentioned before, where we'd go to poor performing hospitals and we'd ask them kind of what's going on and try to help them troubleshoot. And we actually saw a lot of improvement with this. So if you look over time from about mid-2017 to right before the COVID-19 pandemic, you can see that the number of patients with asymptomatic bacteria treated over time really fell quite dramatically. We had a 49% relative decrease in the amount of asymptomatic bacteria that was treated. If you look at the number of patients who were treated for 5 days for community-acquired pneumonia, you similarly see an increase in the number of patients appropriately treated. It was about 117% relative increase. And this one was actually also associated with a reduction in antibiotic-associated adverse events. So less C. difficile, less rashes, and less events after discharge. So this is a lot of great improvement that we were really seeing. And then at about that time, COVID hit and the pandemic came, and we really had to take a detour and think about what we were doing. So just to show you kind of how bad things got in the state of Michigan, right around here, kind of late March, you can see we had an exponential rise in the number of hospitalized patients with COVID-19. Our hospital typically has about 950 beds. The tough part about this for us was that most of these patients were transfers from other hospitals in Southeast Detroit, which had really been hit hard. And so they were sending us patients that required intensive care. And so at this point up here, we actually had about 150 patients in our ICU at a time, just with COVID. And so we had to build 4 additional ICUs to take care of these patients. At about this same time, we started constructing a field hospital because we thought this number was going to keep going straight up. We were really fortunate because right around April 1st, our governor issued a massive statewide stay-at-home order. And so we saw about 14 days later, our cases started to level off and then fortunately started to improve. And we've been at kind of a low steady state for the last 3 months or so. But right here, really scary. And I know you guys are still kind of in this space right here. So I hope you too start to see a decrease. So it was about that time when we started seeing this surge in cases kind of in late March that we started thinking that maybe we needed to stop focusing on pneumonia, stop focusing on urinary tract infection, and start focusing on COVID-19, which is all anyone could really think about at that time, and which was the majority of patients in most of our hospitals. And that's when we decided to create a new initiative called My COVID-19. So just to give you a timeline of how things happened, kind of early March 10th, we had the first case of COVID-19 in Michigan. I actually had the fortune of taking care of this patient, and he's been in multiple newspaper articles since here. He had a double lung transplant and then ended up getting COVID-19. And so he was actually in our hospital for weeks as we were trying to figure out a safe place for him to go to leave the hospital. By a couple weeks later, we had started discussing the fact that we needed to start collecting data on these patients. Within a week, we had finalized our data collection strategy, which the only way you can create a data collection strategy in a week is to have most of it built ahead of time. And it was really helpful because we adapted a lot of the things we'd done with pneumonia and with sepsis to this initiative. The database went live kind of 4 days after that. By early April, we had 20 volunteer hospitals and then 36 volunteer hospitals. And by the end of the initiative, we ended up with 2,000 patients at 38 hospitals across the state with COVID-19 who we had data on. So how do you really work and start a new collaborative quality initiative in just under a month? Well, the key, and the key is in the title, is collaboration. And I really mean it. Collaboration was super important with this group because there was so much work and we needed a lot of expertise and a lot of people. And then, as I mentioned before, we really used the existing infrastructure and just kind of tweaked it a bit to get things running and off the ground quickly. This is kind of a list of all the different specialties that helped us from across the state. So hospitals kind of started this, but obviously we needed all sorts of different people to help. And then all of the different initiatives across the state that helped. These were other collaborative quality initiatives that joined with us to provide specific elements and data collection tools. And really, we couldn't have done this without all of them as well. And then the existing infrastructure. So as I mentioned, we borrowed pneumonia and sepsis data collection tools. This was really key early on to get up and running very quickly. We also borrowed data abstractors from other initiatives. So a lot of these collaborative quality initiatives had people who were tasked with collecting data for them at different hospitals, and we borrowed them and repurposed them to collect data on patients with COVID. And then we used existing underlying tech platforms instead of inventing anything from new. And then another thing that nobody ever thinks about, but it was really important for our data analysts, was we used existing data codes. So we had already done things like categorize what appropriate antibiotics is, how you define an infection, how you define, for example, whether a blood culture is positive or a contaminant, and done that all in the background with data analytics. And so we were able to kind of easily transition that to this new initiative without having to create it from scratch. And that allowed us to get data and information out to our partner hospitals really quickly. So what did we learn from this process? Well, I think nothing will be too surprising, but about our overall kind of cohort of patients. I'm sure it's kind of mirrors what you guys have seen. But these are kind of our overall clinical characteristics of patients with COVID in Michigan. So the vast majority of them came from home, mostly through the ER. The median age was 63, and we had an equal split of men and women. We did have quite a large number of patients who were African American or Black, about half of our patients, and that's because Southeast Michigan and Detroit was hit so hard, and there's a large African American population in that part of the state. Patients tended to be a little bit heavier with a median BMI of 30.6. About 2/3 were non-smokers, and then the comorbidities that were common are shown there. So about 2/3 had hypertension, a third had diabetes, a quarter had cardiovascular disease, and another quarter had kidney disease. Patients tended to have about 6 days of symptoms before they came into the hospital. And when they did come in, they tended to have things like cough, which was often dry rather than productive, shortness of breath with hypoxia. The hypoxia was often out of proportion to their shortness of breath. And then they often had gastrointestinal symptoms like nausea, vomiting, or diarrhea. Fatigue was often prominent, as was a persistent fever that often occurred daily and wasn't really relieved by NSAIDs or acetaminophen. So that's kind of the overall description of the cohort. I want to really focus in and dive into the antibiotic use piece now. So some of the key questions we had related to antibiotic use in COVID are things that we've talked about earlier in this talk. So how often are empiric antibiotics prescribed when patients are first admitted or first hospitalized? And then how common are community onset bacterial co-infections? And if you have this information together, it can really help you develop an idea of what clinical situations warrant empiric antibiotic use in patients with COVID-19. So should you prescribe antibiotics to that patient that we talked about kind of in the beginning of the presentation? And all of the data that I'm about to present is actually just published online a few days ago in Clinical Infectious Diseases if you want additional information from there. But long story short, what we found is that there's a lot of antibiotic use, especially when patients are first hospitalized. We found that 56.6% of hospitalized patients with COVID received empiric antibiotic therapy in their first 2 days of hospitalization. And we actually found that this wasn't the same across hospitals. There was quite a bit of variation. Here you see each bar is a hospital, and the y-axis shows you the percentage of patients who received empiric antibiotic treatment. And you see quite a bit of difference. So there are some hospitals where fewer than 30% of patients get antibiotics, and some where it's almost all of their patients get antibiotics. You also see a difference in which antibiotics are used. The blue bars here represent antibiotics that target community-acquired pathogens only, so antibiotics like ceftriaxone or Unicen. And then the gray here shows antibiotics that target either MRSA or Pseudomonas. So the patients receive something like vancomycin or Zosyn or cefepime. And then the green is other antibiotics, which obviously weren't used that frequently. The predictors of early empiric antibiotic use, I think, are things that we'd all kind of expect. So patients who were older, those who required respiratory support or were otherwise severely ill. Interestingly, patients with a lower BMI were more likely to receive empiric antibiotics. And then we also saw that patients who had a lobar infiltrate instead of this diffuse or negative chest x-ray were also more likely to get antibiotics. And then interestingly, we found some other unique characteristics that were associated with empiric antibiotic therapy. For example, we saw that for-profit hospitals were more likely to treat patients empirically. And actually, if you go back to this graph here, the arrows here are our for-profit hospitals. And you see that 4 of them are in the top 5 hospitals in terms of antibiotic use. So we're not 100% sure why our for-profit hospitals were using so many antibiotics, but it was a very strong trend that we saw here. The other thing was that we saw that patients that were admitted in March versus April or May were more likely to receive empiric antibiotics. And so you can actually see that here in this trend. If you look at patients admitted in March, about 2/3 of them received empiric antibiotics, and that number dropped to 50% in April and May. We saw over the same period of time that the time it took for COVID-19 tests to come back actually improved, and we wonder if that may explain some of this. So this line here shows the percentage of patients who had a COVID-19 test return within 1 day. And you see in March that our tests were taking a really long time to come back. So only about 50% of our patients had their COVID-19 test come back in a day, whereas that number was over 80 and then almost 90% by May. So what you saw was that empiric antibiotic use decreased as the COVID-19 test turnaround time improved. And so this is one hypothesis in theory for why empiric antibiotic use decreased over time. I will also say that microbiologic testing is very difficult in patients with COVID-19. Here's kind of our general rates of testing that we saw. So about 2/3 of patients had some sort of blood or respiratory culture. the majority of those had blood cultures. And actually, it was a very, very small number of patients who had some form of respiratory culture, whether that was a sputum or a BAL or anything like that. There was actually a pretty high number of patients who had non-culture tests. So for example, a respiratory polymerase chain reaction test, or a urine Legionella, a urine pneumococcal antigen. And just to put that in context, when we looked at patients with pneumonia in these same hospitals kind of a year before, here's what those numbers looked like. We saw that almost every single patient had a blood culture, about a third of patients had a respiratory culture, and a lot fewer patients had these other types of tests performed. So it's really interesting here. I think what you see is that there's a larger reliance on kind of non-invasive testing that doesn't put healthcare workers at risk to try to get information about pathogens. And this makes sense if you think about the type of sputum that patients with COVID produce. In fact, sputum production is quite uncommon. It was only reported in 13% of our patients, and that's compared to about half of patients that typically have bacterial pneumonia. And so if patients aren't producing sputum on their own, you typically have to induce sputum in order to get a good culture. And for healthcare workers and our respiratory technicians and the risk of aerosolization with sputum induction, that's actually potentially dangerous. And back in March and April, we didn't have a lot of personal protective equipment. So things like that were just not being done because we wanted to protect our healthcare workers. So with all of that in mind, recognizing the fact that there were fewer tests than we normally do, what we actually found was interesting, and that community onset bacterial co-infections were quite rare. In fact, only 3.5% of patients that we had a confirmed bacterial co-infection. About 1.8% of those had a blood culture that was positive, and 1.7% had a respiratory test, whether that was a urinary antigen, a PCR, or a culture that was positive. And that meant because so many of these patients were treated with antibiotics who didn't actually have an infection, that our number needed to treat was 20. So for every 20 patients treated with antibiotics, only one of them actually had an bacterial infection. So quite a big difference there, and a number we can improve on. So what kind of patients actually had co-infections? What were our predictors of community onset co-infection? We found that older patients and those with more severe disease were more likely to have co-infections. Severity meaning they were in an ICU, they were on a ventilator, they had sepsis or severe sepsis. We also, interestingly, again, saw that patients with a lower BMI were more likely to have bacterial co-infections. And then patients with more comorbidities, in particular those with kidney disease, were more likely to have a co-infection when they first came in the hospital, as were patients who came from nursing homes. So these are all patients that you should maybe think about treating empirically with antibiotics. The two other things that were really helpful were actually laboratory tests. So we saw that patients with co-infections were more likely to have high white blood cell counts. If you think about it, most patients with COVID actually have lymphopenia. So seeing that high white blood cell count instead should trigger the thought of thinking about a bacterial co-infection. And then one of the other markers that we saw was really elevated in patients with co-infection was a procalcitonin test. And I'll talk about that a little bit more because I know it's not as widely used in Brazil as it is in the United States and elsewhere. But procalcitonin is a chemical released from thyroid neuroendocrine cells under systemic inflammation from bacterial infection. And interestingly, it's typically not released due to viral infections. And in the past, procalcitonin has mainly been used as a marker to help people decide when to stop antibiotics or shorten antibiotic duration in patients with pneumonia. And what you look for there is a drop in procalcitonin. So the number starts out high, and then after it drops by a certain amount or goes back to normal, you can feel safe stopping antibiotics. But there's mixed data on what people would love to use it for, which is deciding whether a patient needs antibiotics to begin with. And so some people have looked at it for deciding between heart failure and pneumonia, or between a COPD exacerbation and a bacterial pneumonia. And there's been mixed results about that. Here's what we found on it in COVID. If you look on the left-hand side of the column here, you'll see different cutoffs we tend to consider this cutoff here to be low risk, this to be slightly higher than low risk. And right about here is where we generally tend to say that you should go ahead and start antibiotics. This is medium risk and this is high risk. And you'll see that patients with confirmed co-infection were more likely to have kind of this high number here. What you also see is that there's a pretty wide distribution of this result for patients without co-infection, which shows that this isn't a good way of actually determining if a patient has a test or if a patient has an infection. So if you look at different cutoffs here, you actually see that this cutoff of 0.5, which is the high risk, really only has a positive predictive value of about 9%. So a patient that has a positive value is only 9% chance of actually having a co-infection. On the other hand, a negative predictive value is quite good of 0.1. So if you have a patient that has a negative procalcitonin, you can feel pretty confident that they do not have a bacterial co-infection. So how has this changed my practice? So if I'm not going to give a patient antibiotics, if I don't think they have an infection, I don't get a procalcitonin because the positive predictive value is quite low. But if there's a patient I'm on the fence with and I'm thinking about giving antibiotics, I get the procalcitonin. And if it's negative, then I don't give antibiotics. So that's kind of how I've used this test. So I know that you guys are more likely to use CRP or C-reactive protein. So I wanted to show you kind of some of the data around that. And what we found in our study is that C-reactive protein was not associated with bacterial co-infection in patients with COVID. And here are kind of the numbers there. And you see different cutoffs again here. Here are your values for patients with a confirmed co-infection. You do see that those with confirmed co-infection are more likely to have high values, but it's also true that those without a confirmed co-infection are likely to have high values. And so what you see is that whatever cutoff you use here, your sensitivity, specificity, and positive predictive value is pretty poor. I will say that the negative predictive value of a CRP cutoff of 10 is 98%. So if you happen to have a patient who has a CRP of less than 10, their chance of having a co-infection is quite low. But other than that, it's not really a good test for ruling in a co-infection, but a better test for ruling out a co-infection. So that's a lot of information. I want to leave you with some key takeaways and things that we learned from this study, and then take some questions. But I think the big thing we found is that empiric antibiotic use in patients hospitalized with COVID was common, varied widely across hospitals, and is fortunately decreasing over time. And we think that much of this antibiotic use is likely unnecessary. We found a number needed to treat of around 20. So we can definitely do a better job of trying to target antibiotics to patients who are at higher risk. Like I mentioned before, bacterial co-infections were quite rare. They only occurred in about 3.5% of patients. So it's something that I think later on during the hospitalization we need to worry about after they've been put on a ventilator, spent weeks in the hospital, and given things like steroids or other immune modulating medications. Those are the patients that develop co-infections. But when they first come into the hospital, they're quite uncommon. We also found that antibiotic stewardship appears to be able to help. So I didn't show you this data, but there was some interesting stuff that we looked at. And we saw that hospitals that had a lot of stewardship resources and better antibiotic use before COVID, so when we looked at that duration and asymptomatic bacteria in like 2019, if they were doing well then, they did well during the COVID surge. So I think it shows that having the infrastructure in place and the culture of stewardship can help during the pandemic as well. And then procalcitonin may be able to help, especially if it's something that's available to your hospital, but should really be used more for its negative predictive value than for its positive predictive value. And then we found that there were other risks associated with co-infection that should make you think that maybe a patient could have a co-infection. Those are things like older age, coming from a nursing home, having really severe disease at illness onset, and think about that white blood cell count because an elevated white blood cell count is atypical in patients with COVID-19. And then clearly more of a systems issue is that a quick COVID-19 turnaround time is really key, because if you're spending time not knowing whether your patient has COVID or has something else, it's really hard to withhold antibiotics at that time. And so knowledge is power, and the quicker we can get knowledge to our physicians, the better. So I really appreciate you guys coming today. I want to thank you all for listening to me and for letting me speak with you. And I look forward to any questions you might have.
So thank you. Amazing presentation.